Hello everyone. I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing the very important topic in the cardiology, that is the atrial fibrillation treatment. So in the previous section, we have discussed in detail about what is the etiopathogenesis of the atrial fibrillation and what will be the clinical presentation and how do you diagnose atrial fibrillation. So all that we have discussed in the previous section. So in this, I'll try to teach you like how to handle the patient of the atrial fibrillation. So in the atrial fibrillation, the treatment is like you need to first decide whether the individual is hemodynamically stable or hemodynamically unstable. If the individual is hemodynamically unstable, first and foremost very important is cardioversion, then the subsequent treatment. And if the individual is hemodynamically stable, then what is very important is rate control, rhythm control, and then antiplatelets and anticoagulants need to be given. And the very important aspect of the treatment is those individuals who are refractory to medical management. In those patients, you need to do the catheter ablation, or we have surgical procedures called Cox-Maze procedure. Now, why is it you are giving antiplatelets or anticoagulation? That is mainly to prevent the thromboembolism. But certain group of individuals, they cannot tolerate this anticoagulation or antiplatelets. They have the bleeding tendencies. So in those patients, you need to place a device in the left atrial appendage, and the name of that particular device, we have Watchman device, we have Lariat device, all that I'll be discussing in detail. Okay, so this will be the overview of the treatment of the atrial fibrillation. Now, first, let me just tell you what all headings we'll be discussing in the treatment. Right, so I'll be discussing what exactly are the main goals in the treatment. Then cardioversion and anticoagulation. Is it like cardioversion first or is it like anticoagulation first? I'll discuss that. Then how to achieve the acute and as well as the chronic rate control. Then stroke prevention in atrial fibrillation, rhythm control, catheter and surgical ablation for maintaining the sinus rhythm. What exactly you mean by this word hybrid procedure, risk factors, and lifestyle impact on the atrial fibrillation. So all these we'll be discussing in this session now, right? So now first, what are the treatment goals? So the treatment goals are first and foremost, achieve the rate control, right? Achieving the rate control, very important, okay? Why? Because of increased rate, the patient is having the palpitations, discomfort in the chest. So achieve the rate control. And not only that, the other advantage of achieving the rate control is there will be increase in the diastolic filling time of the ventricle and cardiac output increases. So that is the reason why you need to achieve the rate control and subsequently the rhythm control. And then you need to give antiplatelets and anticoagulants to prevent the thromboembolism. Then you also need to handle the risk factors like hypertension, diabetes mellitus, dyslipidemia, rheumatic fever, mitral stenosis or mitral regurgitation, cardiomyopathies, coronary artery diseases, right? So, and hyperthyroidism, pheochromocytoma. So all these risk factors you need to handle, okay? Right. Now, the point is like if you take what exactly is the indication of the emergency cardioversion in case of atrial fibrillation, right? And this emergency cardioversion you will be doing in either ways. Either you can do the electrical cardioversion, right, which is more preferable, or you can do pharmacological cardioversion. If electrical cardioversion is not available, then go ahead with the pharmacological cardioversion. But first of all, what is the indication for the emergency cardioversion? The indication is the patient is having an acute atrial fibrillation, and this acute atrial fibrillation is causing hemodynamic compromise, right? It is causing the hemodynamic compromise, okay? That is one indication. Hemodynamic compromise is hypotension, tachypnea, tachycardia, that will be hemodynamic compromise. And the other indication is because of acute atrial fibrillation, the patient has developed pulmonary edema. That is another indication for the emergency cardioversion. And next is acute AF with evidence of, right, with evidence of the coronary ischemia. right, with evidence of the coronary ischemia. In this case also, you need to do emergency cardioversion. So how can you achieve that? Either by electrical or the pharmacological cardioversion. But which is more preferred? Electrical cardioversion is more preferred than the pharmacological cardioversion. And this electrical cardioversion is achieved by DC shock. Okay, and that too, it should be a synchronized DC shock, right? That too, it should be a synchronized DC shock, and this particular DC shock, it should be around 150 to 200 joules, and this synchronization should be with the QRS complex on the ECG. And very important is, whenever you are giving the DC shock, preferably the patient should be in a sedated state, because the conscious patients, they cannot take the DC shock of 150 to 200 joules. So preferably the individual should be in a sedated state. And if you are planning for the pharmacological cardioversion, it is achieved by intravenous class 3 antiarrhythmic drugs. And which is that class 3 antiarrhythmic drug that you will be giving intravenously? That is ibutilide. Now, when you are supplementing this ibutilide, there are certain limitations. What are these limitations with the ibutilide? The limitations are that if there is baseline QT prolongation, then don't give ibutilide, because ibutilide can make the individual with QT prolongation to progress to the development of Torsades de Pointes, that is polymorphic ventricular tachycardia. And another important limitation of the ibutilide is if there is severe LV dysfunction, right? That is also a reason why the ibutilide should not be given, right? So this is like in case of hemodynamically unstable patients, what is that you will do in a case of atrial fibrillation? Now, you take a case of the hemodynamically stable patients. Hemodynamically stable, just now we have discussed rate control, then rhythm control, and then the anticoagulation. As usual, whatever we have discussed in the beginning. Now the point is, whether to do cardioversion first or whether to give the anticoagulation first, right? This is a very, very important thing to decide. So what is that cardioversion you will be doing? The cardioversion is that where the irregular rhythm of the atrial fibrillation will be converted into the sinus rhythm. That is what you mean by the word cardioversion, right? Now, whether to give anticoagulation first or whether to do cardioversion first, let me discuss. Now, if the duration of the atrial fibrillation is more than 48 hours, or if the duration of the atrial fibrillation is like unknown duration, in such case, if you do cardioversion first, there is increased risk of the thromboembolic complications. Okay, either it might be electrical cardioversion or it might be the pharmacological cardioversion. Remember, if the duration of the atrial fibrillation, if it is more than 48 hours or unknown duration, then don't do cardioversion first. If you do cardioversion first, there is increased risk of thromboembolic complications. So in which scenario we are discussing this? We are discussing this scenario in a case of acute atrial fibrillation, right? Not in a story of chronic atrial fibrillation. Okay, right. So in case of acute atrial fibrillation, if the duration of the atrial fibrillation is more than 48 hours, then what is that you have to do? You have to give the anticoagulation first, right? You have to give anticoagulation first. Okay, right. Now that too in acute atrial fibrillation in individuals who are hemodynamically stable, right? Hemodynamically stable, not in case of hemodynamically compromised individual. Hemodynamically compromised individual, there is no waiting period at all. Immediately you need to do cardioversion, right? Right. So now, so you need to give the anticoagulation first, right? Or if you want to do cardioversion, right, you don't want to give anticoagulation first. If you want to do cardioversion, then in such case, you need to exclude the left atrial appendage thrombus. Right, you need to exclude the left atrial appendage thrombus. Okay, now how will you exclude or how will you evaluate the left atrial appendage thrombus? One is by doing your transesophageal echocardiography, and the other one is by the cardiac CT. Right, the other one is by cardiac CT. So both of them, you know, they have excellent sensitivity and as well as specificity for diagnosing the left atrial appendage thrombus. Okay, right. So now, what are all the conditions where you need to give anticoagulation? First, the duration more than 48 hours, right? Unknown duration. And one more thing is, right, one more thing is, in individuals who are having the high risk of developing thromboembolism. Now, who are those high risk individual for thromboembolism? The high risk individuals are, number one, patients with mitral stenosis, patients with the hypertrophic obstructive cardiomyopathy, right? In these individuals, right, these three groups, number one, atrial fibrillation duration more than 48 hours. Number two, unknown duration. Number three, high risk individuals. In these individuals, let me tell you, you need to give anticoagulation first, then you need to do cardioversion. Okay, because if the duration of the atrial fibrillation is like more than 48 hours, like the atria is like feebly contracting, there is stasis of the blood and there is thrombus formation within the LALA, that is left atrial appendage, and that can shower an emboli also. So that is the reason why you need to give anticoagulation first. If you are doing cardioversion first, right, you know what can happen? The restoration of the sinus rhythm, right, the restoration of the sinus rhythm, it will increase the risk of the thromboembolism, right? That is the reason why anticoagulation you have to give first, right? Then you need to do cardioversion. Okay, right. Now the next is, now if suppose the duration of the atrial fibrillation, if it is less than 48 hours, right? The duration of the atrial fibrillation is less than 48 hours, okay, of onset. Then in such case, these patients, they don't require anticoagulation first. Okay, so right, what you have to do in these, so cardioversion within 48 hours of onset of atrial fibrillation is common practice in patients who have not been anticoagulated. So in them, cardioversion, and then later, depending upon the risk, you need to do the anticoagulation. Okay, so that is very, very important, whether cardioversion first or whether anticoagulation first, right? And this is a very important point. If the duration is more than 48 hours, if the duration is unknown, or if the individual is high risk individuals, they have to be definitely given the anticoagulation. Even though, right, even though your CHA2 DS2 VAS scoring system, right, even though CHA2 DS2 VAS scoring system, even though it is less, you have to give anticoagulation first. Okay, right. So this is about like anticoagulation first or the cardioversion first. Now, in which scenario we have discussed until now? Acute AF in hemodynamically stable patients. Okay, right. Now, okay, one more point is about the, right, one more point is about the long-term maintenance of the anticoagulation, right? How long you need to give the anticoagulation? See, for how long you have to give anticoagulation is that it all depends upon the CHA2 DS2 VAS scoring system, right? And how can you mitigate or how can you reduce the risk of thromboembolism? There are two strategies, right? One, anticoagulation, and the other one is the TE or CT scan. What is this? Let me explain to you. In the first approach, in case of acute AF with hemodynamically stable, what you have to do is anticoagulation should be given first for nearly around 3 weeks, right? Then you do cardioversion. After cardioversion, again you give anticoagulation for another 4 weeks. That is one strategy of reducing the thromboembolism. The other strategy is, second strategy is that you start anticoagulation, right? You start anticoagulation. Then you perform transesophageal echocardiography or cardiac CT, right? If suppose there is no left atrial appendage thrombus, right? If there is no left atrial appendage thrombus, then you do cardioversion. After that, you give anticoagulation. Okay, right? So that means in the second strategy, what is that you are doing? You are not waiting for these 3 weeks in the second strategy. If the TE or cardiac CT is not showing any thrombus in the left atrial appendage, cardioversion and then continue anticoagulation. You need not wait for 3 weeks in the second approach. So in both of these ways, right, you can reduce the risk of the anticoagulation. And what about the long-term maintenance of the anticoagulation? Long-term maintenance of anticoagulation completely depends upon the individual risk for stroke, right? The individual risk for stroke, it depends upon your CHA2 DS2 VAS scoring system, which I will be discussing that in detail. Okay, so that is about the whether cardioversion or the anticoagulation, right? Now, how will you achieve that acute rate control, right? You are giving anticoagulation and you are doing a cardioversion. So cardioversion, basically what is that you are doing? Number one, you are controlling the rate, and number two, you are also controlling the rhythm. Now, how will you control the rate, right? That is acute rate control. Now, first and foremost, why to achieve the rate control? I have already said you in the beginning itself. By achieving the rate control, right? So in AF, right, how much will be the heart rate? It will be definitely more than 100. Okay, so it will be in a range of 150 to 200 also at a times. What I am talking about 150 to 200 is ventricular rate, not the atrial rate. Now, at this particular rate, what will be the diastolic filling time of the ventricle? Diastolic filling time of the ventricle will be very less. Now, when the diastolic filling time is very less, right, the cardiac output will be reduced. So that is the reason why by achieving the rate control, you will increase the diastolic filling time. Right, by achieving the rate control, right, you will increase the diastolic filling time, and thereby there will be improvement in the cardiac output, and thereby there will be reduction in the clinical features, right, reduction in the symptoms of the individuals. Okay, right. Now, if you take the long-term effects of the rate control, what is the advantage you are getting? What is your heart getting the advantage? So long-term effects of the rate control is that will minimize, right, that will minimize the risk of congestive heart failure, right? And the another important advantage of the rate control is the tachycardia induced, right, tachycardia induced cardiomyopathy, right, tachycardia induced cardiomyopathy, this can be reduced. Okay, so that is the long-term effects of the rate control. Now, how is that you will achieve the rate control? So we have two important group of drugs. One is beta blockers and the other one is the calcium channel blockers. And the beta blockers that we give is cardioselective beta blockers, that is beta 1 blockers like metoprolol or the atenolol should be given to achieve the rate control. And calcium channel blockers are the diltiazem and or the other drug is verapamil, right? Diltiazem or verapamil should be given. Now, this particular diltiazem or verapamil should be given either intravenously or through the oral route, okay, depending upon the situation, emergency situation. Okay, now the another scenario is in a case of atrial fibrillation with congestive heart failure. In this case, digoxin is being used for many years. Okay, because this particular digoxin will not only reduce the ventricular rate, digoxin, right, it also has the inotropic effect which will increase the cardiac output, right, which will increase the cardiac output. That is the reason why if it is AF with congestive heart failure, preferably you need to give digoxin. Okay, or the another place where you can give digoxin is you are giving beta blockers, right, or you are giving calcium channel blockers. If the rate control is not achieved, then also you can add this particular digoxin. Okay, but digoxin is associated with its own toxicities. That recent evidences, it has suggested that usage of digoxin, it has increased the mortality rates in patients with the atrial fibrillation. That is the reason why the digoxin use is limited, right? Utilization has declined. So this is how you will achieve the acute rate control. Then the next is the chronic rate control, right? Now what will be the goal of the chronic rate control? See, patients who are having atrial fibrillation chronically, the goal of the chronic rate control is to reduce the symptoms of atrial fibrillation by improving the cardiac output, and the another important goal is to prevent the deterioration of the ventricular function, right? Prevent the deterioration of the ventricular function. Okay, so these are the goals of the chronic rate control, right? Now, what are all the drugs used for chronic rate control? And almost the same drugs what we use in acute, but here what we give is oral. They don't require intravenous. In acute, they are requiring intravenous here, in acute, but in chronic, right, we give the oral beta 1 blockers, or you need to give the calcium channel blockers, right? You need to give them either alone or they are given in combination, right? They are given alone or in combination, they have to be given. Okay, right. Now, strong indication for the rate control in AF is the exertion related symptoms. Okay, exertion related symptoms are often an indication of inadequate rate control. That means upon exertion, if the heart rate of the individual is excessively getting increased, that tells that the heart rate which has achieved with this is not adequate. Okay, so exertion related symptoms are often an indication of inadequate rate control. Okay, so this particular rate should be assessed with exertion, and accordingly the medications have to be adjusted. Okay, even with exertion, the heart rate should be controlled. Accordingly, the dosage of your beta blockers and calcium channel blockers have to be adjusted. Now, how much is your goal of the resting heart rate? The resting heart rate in a case of the atrial fibrillation, it should be less than 80 per minute, right? And on exertion, it may increase up to 100 per minute, right? The goal should be less than 100 per minute with light exertion. What is that light exertion? That is walking, right? But in case of atrial fibrillation, it is not that easy to achieve this particular goal. So, what is the accepted goal? Right? What is the accepted heart rate? Right? It is very difficult to slow the ventricular rate to this particular degree of less than 80 or less than 100 per minute. So in such case, the acceptable heart rate control, it should be around 110 beats per minute. That is accepted. And the other thing is, the rate control, whatever you are achieving less than 110 per minute, it should not cause, okay, the symptoms, right? The symptoms should be minimized, right? The symptoms should be minimized with this particular rate, okay? And even the ventricular function, right? Even the ventricular function, that should be normal, right? Even the ventricular function also should be normal, okay? That is what is the acceptable heart rate. And what do you mean by the word ventricular function will be normal? That is, if the ventricular rate is more than 110 per minute, it will go into a state of tachycardia induced cardiomyopathy. That should not happen, right? That is what is your acceptable heart rate, okay? Right. Now, the point is, if adequate rate control in atrial fibrillation is difficult to achieve, then in such case, what is very important is you need to plan for the restoration of the sinus rhythm, right? If you're not able to achieve the rate control, right, parallelly you need to plan for the restoration of the sinus rhythm, okay? Right. Now, what is the one method if the individual is refractory to beta blockers, refractory to calcium channel blockers, refractory to digoxin? Then what is the surgical intervention that you can do to achieve the rate control, right? There is one particular strategy called as the ablate and space strategy. So what you need to do is you need to plan for the catheter ablation of the AV node. When you do this catheter ablation of the AV node, this will cause permanent AV node block, right? This will cause permanent AV node block. And after this permanent AV node block, then you plan for the placement of the permanent pacemaker, okay? Implantation of implantation of the permanent pacemaker, right? And by placing the permanent pacemaker, you will be able to set the heart rate what is required for the individual. So what is that you are doing? First you are ablating, and then later on you are pacing. This is what is called as the ablate and as well as the pace strategy, right? And but you have to understand that for controlling the heart rate, these patients, they are completely dependent on the pacemaker, right? So to maintain that ventricular rate, they are completely dependent on the pacemaker. Now, which particular pacemakers do we need to use, right? We have the single chamber ventricular lead pacemaker, that is single chamber pacemakers, and the other one is dual chamber pacemakers, okay? Right. Now, if you do the pacing with single ventricular lead, right, that single ventricular lead, where is that you will place? You will place it in the RV apex. Now, when you do the pacing with single ventricular lead, that is the right ventricular apex, that will induce, right, that will induce dysynchronous, right, that will induce dysynchronous ventricular activation, right, that will induce dysynchronous ventricular activation, okay? Now, this dysynchronous ventricular activation, it will reduce the ventricular function, right? It will reduce the ventricular function, okay? That is the disadvantage of using the single chamber pacemaker. So that is the reason why what is being preferred is the biventricular pacemaker, okay? Biventricular pacing, or you need to do direct pacing, right? You need to plan for direct pacing of the his bundle or the left bundle branch, okay? You need to do direct pacing of the his bundle or left bundle branch, okay? That will minimize right? That will minimize the degree of the ventricular dyssynchrony. So that is the reason why biventricular pacing is more important rather than the single ventricular pacing, right? So this is how you can achieve the rate control, right? One is beta blockers, calcium channel blockers, digoxin, not achieved, then ablate and pace strategy, right? Now, the next important is, let us try to discuss the stroke prevention in the atrial fibrillation. We have discussed in the section of the introduction to atrial fibrillation that these patients are at increased risk of stroke. Okay, so the development of stroke or the thromboembolic complications, particularly the stroke, that is the life-threatening sequelae of the atrial fibrillation. So that is the reason why appropriate stroke prevention strategies, they are the key aspect of the AF management. Now, what will be the mainstay of the stroke management? That is giving a continuous anticoagulation therapy, right? Usually the oral anticoagulation you need to give. And remember, we have a specific population group which is considered as the high risk for stroke. Now, what is that particular population group which is considered as the high risk for stroke? That includes hypertrophic cardiomyopathy patients. Number 2, mitral stenosis. Number 3, past history of stroke. In these individuals, remember, you definitely have to give the anticoagulation. You definitely have to give anticoagulation. Okay, anticoagulation is definitely recommended, right? The another point is, if there is development of atrial fibrillation without mitral stenosis, that is being referred as non-valvular AF, right? That already we have discussed. Now, the next point is, in majority of the patients with AF, the decision about whether a stroke prevention regimen is indicated is largely based on assessment of the stroke risk. How do you assess the stroke risk? That is by your CHA2DS2 VAS scoring system, balanced by risk of preventative therapy. So, how will you assess the stroke risk is by your CHA2DS2 VAS scoring system, which I'll be discussing that in detail, right? So, this CHA2DS2 VAS scoring system, it is widely used tool to estimate the stroke risk. Okay, that is cardioembolic stroke, right? Now, what is the indication of anticoagulation in this case is, if the CHA2DS2 VAS scoring system is like more than or equal to 1, then it's a classical indication of starting the anticoagulation. Okay, now if you don't give anticoagulation, what is the risk of stroke? Definitely the stroke risk increases. And you know how much is the annual stroke risk? The annual stroke risk without anticoagulation may be as high as 20% without anticoagulation, right? There is 20% chances of the development of the cardioembolic stroke. Now, if you take this CHA2DS2 VAS scoring system, the word C stands for the congestive heart failure, right? Then A is age, that is A2. Age more than 75 years, you need to give a score of 2. And this particular H, it stands for hypertension. Okay. Then D stands for diabetes mellitus, give a score of 1. S2, that is if there is past history of stroke, give a score of 2. If there is past history of like vascular diseases like coronary artery disease, peripheral arterial disease, cerebrovascular accidents, then give a score of 1, right? If there is vascular disease, okay, right, not the prior stroke. Vascular disease, give a score of 1. Age more than 65 years, give a score of 1. Gender, female gender, give a score of 1. So now when you calculate this particular score, if it is like more than or equal to 1, you need to definitely give the anticoagulation, right? If the score is 0, right, what we just give is only the antiplatelets. Okay, and if the score is 1, either anticoagulants or antiplatelets should be given. And if the score is like more than 1, you need to give the anticoagulation. If the score is more than 1, you need to give the anticoagulation, definitely. Okay, so this is what is your CHA2DS2 VAS scoring system, right? Now the point is, whenever you are giving this anticoagulation, there is also parallelly the bleeding risk, right? There is also parallelly the bleeding risk. And what are the bleeding complications that can happen is, that includes intracranial hemorrhage, and there can be also development of the gastrointestinal bleed. So this is about your anticoagulation risk. Now, what is the chance of bleeding risk? That is being decided by a scoring system called the Hess-Bled score. Now, what is this Hess-Bled score? The Hess-Bled score stands for, H is hypertension, give a score of 1. A stands for abnormal renal and liver function, give a score of 1. S stands for the individual having the bleeding diathesis, give a score of 1. The word B, here B, okay. So B, give a bleeding diathesis, give a score of 1. L stands for labile INR, give a score of 1. Then age of the individual, right? Age of the individual more than 65, give a score of 1. And if the individual is on any previously antiplatelets, or if the individual is alcohol abuse, then give a score of 1. Okay, so this is what is your Hess-Bled score. More is your Hess-Bled score, more is the chances of the bleeding risk, right? So in this Hess-Bled score, the word S stands for the stroke, and if there is stroke, then give a score of 1. So more is the score, more is the chances of developing the bleeding. Now this anticoagulation, if you see, what are the various anticoagulants that you can give? One group of drugs is your NOACs, and this particular NOACs, it stands for newer oral anticoagulant drugs. And what are the examples of these newer oral anticoagulant drugs? We have a direct thrombin inhibitor, and this direct thrombin inhibitor is dabigatran. And then we have the factor 10A inhibitors, right? And the examples of this factor 10A inhibitors, they include edoxaban, then apixaban, then we have rivaroxaban. Okay, so this is about your 10A inhibitors. Now the next group of drugs are the vitamin K antagonists, and this vitamin K antagonist, they include the warfarin, right? Vitamin K antagonist, it includes the warfarin. Okay, so this is about how you need to give the anticoagulation. Now the point is it sufficient if we just give only antiplatelets? Let me tell you, antiplatelets alone, they are not sufficient if the CHA2DS2 VAS scoring system is more than 1. Okay, they are not sufficient. If the CHA2DS2 VAS scoring system is more than 1, antiplatelets alone, they are not sufficient, right? And the next important point is, vitamin K antagonist, that warfarin is the only anticoagulant, right? Warfarin is the only anticoagulant you have to give if it is the valvular AF, right? If it is rheumatic fever associated causing MS or MR causing AF, then you need to give only warfarin. Okay, so warfarin, definitely it will reduce the risk of the thromboembolism. Okay, right. And even there were like head-to-head trials also, right? There were antiplatelets alone in some group of individuals and vitamin K antagonists given in those individuals. What has been shown is, giving antiplatelets alone, it has been found to increase the thromboembolic stroke. Giving antiplatelets alone, right? So antiplatelets alone, they are considered to be inferior to warfarin for stroke prevention, right? Next, now when you are giving this antiplatelets, right? So antiplatelets that you can give is the aspirin and the clopidogrel. right? Aspirin and clopidogrel. Okay, so again, in this antiplatelets also, is it like the aspirin alone, or is it like aspirin and clopidogrel? Remember, clopidogrel combined with aspirin is better than aspirin alone, right? It is definitely better than aspirin alone for stroke prevention, right? But again, only these two drugs if you give, when you compare that with warfarin, definitely the stroke is more with antiplatelets alone treatment. So what I tell you is, if CHA2DS2 VAS scoring system is more than one, definitely you need to add the anticoagulation, right? Only antiplatelets will not be sufficient, right? And the other point that you need to know is those patients who are having atrial fibrillation. Okay, so patients with atrial fibrillation, they are at increased risk of stroke, right? They are at increased risk of stroke. Okay, and they are also at increased risk of venous thromboembolism, right? Not only the cardioembolic stroke, and even they are at also increased risk of venous thromboembolism. But definitely when you give the anticoagulation, the risk of the thromboembolism and stroke will be reduced. And when you compare NOACs with warfarin, which is better? Okay, so the studies have shown that this particular NOACs, they are non-inferior, right? They are non-inferior compared to that of warfarin, right? Compared to that of warfarin, the NOACs, they are non-inferior, and it is the NOACs that are being preferred in non-valvular AF, right? It is the NOACs that are being preferred in non-valvular AF. Okay, now why? Because the NOACs, they have reduced chances of bleeding when compared to the warfarin, right? And there is also reduced risk of the intracranial hemorrhage with NOACs when compared to that of warfarin, right? And another point is, when you are giving NOACs, monitoring of INR is not required. Monitoring of INR is not required. And the onset of action, if you see, right, it will be a quick onset of action for the NOACs. But for warfarin, onset of action, you need to wait for almost 4 to 5 days. So that is the reason why these NOACs are preferred than compared to that of your warfarin. Okay, and what is the indication where you have to give only warfarin, not NOACs, right? That is in case of rheumatic mitral stenosis or the presence of mechanical heart valves. In these two cases, you need to give warfarin only, right? Not the NOACs. Okay, right. Now, this NOACs, what is that we have discussed? That is newer oral anticoagulant drugs. They are avoided, or there are no studies in rheumatic fever. There are no studies in the mechanical heart valves. So that is the reason why in rheumatic mitral stenosis causing AF and mechanical heart valves causing AF, it is preferable to give warfarin rather than the NOACs. And whenever you are giving warfarin, right, what are the things that you need to monitor? You need to monitor the ratio of prothrombin time to that of the INR. And how much should be that? That should be more than 2. And depending upon the PT to INR ratio, you need to adjust the dosage of the warfarin, right? And this particular warfarin, it is having many drug-drug interactions. Okay, so when the patient is already parallelly taking NSAIDs, there is increased risk of bleeding. And when the patient is taking quinolones, the efficacy of your warfarin can get affected. Okay, and there are also many food interactions with the warfarin. That is, if the patient is parallelly taking leafy vegetables, then the efficacy of warfarin will be reduced. So what you should advise the individual is, if the patient is taking warfarin, they should avoid taking leafy vegetables, because leafy vegetables, they are rich in vitamin K, and your warfarin is a vitamin K antagonist. So at one side you are giving vitamin K antagonist and patient is parallelly taking leafy vegetables, it is like you are giving vitamin K supplement to the patient. Okay, so leafy vegetables, they are avoided. Now, what are the advantages of Novax then compared to that of your warfarin? Just now we have discussed. Okay, so it has a very reliable anticoagulant property. That is one thing. And dosage adjustment is not required. Right? Dosage adjustment is not required here. Okay. That in the sense, monitoring of your PT or INR is not required, or APTT is not required in case of the NOACs. The only area where you require dosage adjustment is if there is renal insufficiency. If there is severe renal insufficiency, right, where the creatinine clearance is less than 15 per minute, that is in severe renal insufficiency, then the dosage of the dabigatran, dosage of the apixaban, dosage of rivaroxaban, right? So you can just remember this word dar. Okay, so kya hoga? Like dar jayega. If there is renal failure, don't give full dose of dabigatran, apixaban and rivaroxaban. You need to reduce the dose. Okay, that is the only place where you need to adjust the dosage of the NOACs, right? And because when the creatinine clearance is less than 15, because these drugs, that is your dabigatran, apixaban, rivaroxaban, they have to be excreted through the kidney. If there is renal failure, the levels of these drugs increases in the body and there will be increased bleeding risk. So that is the reason why if there is renal insufficiency, reduce the dosage of these drugs. And one more thing is, the excretion of the NOACs can also be influenced by P-glycoprotein, right? The excretion can also be influenced by P-glycoprotein inducers and as well as the inhibitors. Okay, so that is another interaction that you need to remember. Now, if there is overdosage of these drugs, or if there is development of bleeding, then how will you neutralize the efficacy of these drugs? So reversal of anticoagulation, like for warfarin, patient is taking warfarin, right, and there is excessive bleeding. First and foremost, stop the warfarin. Next is, you can give fresh frozen plasma which contains the coagulation factors, or you can give prothrombin complex concentrate, right? And you also need to give vitamin K. Okay, so this, by doing this, you can neutralize the effect of the warfarin. And for dabigatran, what is the antidote? What is the reversal agent? That is idarucizumab. Okay, that is for dabigatran. Then you take 10A inhibitors. What are the 10A inhibitors? Apixaban, endoxaban and as well as rivaroxaban. For them, it is andexanate alpha. Okay, so this is the antagonist or antidote for your 10A inhibitors. Okay, so this is about how will you do the reversal of the anticoagulation, right? Now, you take this bleeding risk. Okay, you take this bleeding risk with warfarin. You have to understand that what is the chance of bleeding in an individual per year. The major bleeding requiring transfusion and intracranial hemorrhage, it occurs in almost 1% of patients per year with warfarin, right? And because of this bleeding, you know, these patients, they will be requiring the blood transfusion, right? Or the patient can also develop this intracranial hemorrhage. That is 1% risk. Okay, and when you are giving this particular NOACs, that is your direct acting anticoagulants, they appear to reduce the risk of bleeding, right? They appear to reduce the risk of bleeding. Okay, and one point you have to remember is that even though they are reducing the risk of bleeding, at the same time they are not compromising the efficacy of the thromboembolism, right? They will definitely reduce the thromboembolism risk, and at the same time the bleeding risk is also reduced with your NOACs than compared to that of your warfarin. Okay, now this 1% is seen in certain group of the risk factors. Okay, what is that? Age more than 65 to 75 years, they are at increased risk of bleeding. Patient having the heart failure, patient having renal failure, there is prior bleeding risk, they are also at increased risk of bleeding. Or the another important risk factor is excessive consumption of the alcohol. You know, these are the risk factors for increased bleeding when the patient is on warfarin. Okay, so now if you take the dosages of these drugs, like what is the standard dose, when is that the dose has to be reduced and how much you have to reduce, and what is the dose reduction criteria of the NOACs. If you take the warfarin, right, warfarin, the dosage that we start with is, we start with 2 to 3 mg, right? And depending upon your INR, how much should be that INR that should be maintained? It should be definitely more than 2, that is in between 2 to 3, right? In spite of giving 2 to 3 mg, if the INR is not more than 3, then you can increase the dose even up to 5 mg as well, right? And at the same time, you need to check the compliance and you need to check about this leafy vegetable story, which I have said you. Okay, now let me discuss the dosages of these individual drugs. So if you take the standard dose of dabigatran, it is 150 milligrams. Rivaroxaban, it is 20 milligrams, right? And the apixaban, it is the 5 milligrams, and edoxaban, it is 60 milligrams that you need to give, right? That is the standard dose. But if you take the reduced dose of these newer oral anticoagulant drugs, when you should reduce, I'll tell you. The reduced dose, dabigatran, it should be 110 milligrams. Okay, this is a twice daily dose. Okay, so 150 milligrams twice daily, and even reduced dose also, it is 110 milligrams twice daily. And reduced dose of rivaroxaban, it is 15 milligrams once daily, and your apixaban is also, it is twice daily dose, and reduced dose will be 2.5 milligrams twice daily. And edoxaban, the reduced dose will be 30 milligrams. Now you should understand in which scenarios you have to reduce the dosages of these drugs, that is dose reduction criteria. Okay, so now you take dabigatran. Dabigatran dose should be reduced if the age of the individual is more than or equal to 80 years. Elderly individuals, reduce the dosage of the dabigatran. Okay, and if the patient is concomitantly using verapamil, right? Why do we use verapamil in AF? That is for rate control. If the patient is parallelly using verapamil, then also you need to reduce the dose of dabigatran. What is a drug-drug interaction? Remember, verapamil, it will increase the blood levels of the dabigatran. Verapamil increases the blood levels of dabigatran, and thereby there will be increase in the bleeding risk when the patient is taking verapamil. That is the reason why you need to reduce the dose. Okay, right. And the next is the rivaroxaban. So rivaroxaban, when will you reduce the dose age is if the creatinine clearance is reduced. So if the creatinine clearance, if it is in a range of 15 to 49 ml per minute, then you have to reduce the dose to 15 milligrams. Okay, right. Then you take apixaban. Apixaban also, if the age of the individual is more than 80 years, reduce the dose, right? And if the body weight of the individual, if it is less than 60 kgs, then also you reduce the dosage of the apixaban, right? And the another important area where you have to reduce the dosage of apixaban is if the serum creatinine is more than 1.5 millimoles per liter, that is milligrams per deciliter, then also you need to reduce the dosage of apixaban, right? And the next important is the edoxaban. When will you reduce the dosage of the edoxaban? Is same story again. If the creatinine clearance, that is in renal failure, if the creatinine clearance, if it is around 30 to 50 ml per minute, or if the body weight of the individual, if it is less than 60 kgs, then also you need to reduce the dosage of the edoxaban. And one more point is, this edoxaban, it is having the drug-drug interaction with certain drugs like dronedarone. Patient taking dronedarone, reduce the dosage of edoxaban. Patient taking ketoconazole, okay, reduce the dosage of the edoxaban. Patient taking erythromycin, then reduce the dosage of the edoxaban. And patient taking cyclosporin, reduce the dosage of the edoxaban. Okay, so these are the drug-drug interactions for your edoxaban. Okay, so these are the doses, standard doses, reduced doses, and what is the reduction criteria, right? Now, very important is, if the patient is having the bleeding risk, we cannot give any of these anticoagulants, then what is the alternative therapy, right? The alternative therapy is, one, we have, because what is the most common site for your thrombus formation? Left atrial appendage. Okay, so what you do is, you need to do surgical resection of the left atrial appendage, and this surgical resection, it should be combined with the Cox-Maze procedure. Okay, so Cox-Maze procedure is a procedure that is being done within the atria, right? That is being done within the atria. What is that you will be doing in the Cox-Maze procedure? You see here, what is the mechanism of arrhythmia in atrial fibrillation? That is the re-entry phenomenon. That is the re-entry phenomenon. Okay, so these red color lines, they are nothing but your re-entry. Now, how can you prevent this particular re-entry, or how can you minimize this re-entry? By doing the Maze procedure. What is this Maze procedure? You need to create the incisions, right? A series of the incisions, right? The series of incisions, or you need to create the scar. Okay, you see these blue color lines, they are nothing but the incisions, what you have done on the right atrium. So now, by doing this incisions or by creating the scars, what is the advantage? Is that the advantage is that this particular incisions will interrupt the abnormal electrical activity, right? Will interrupt the abnormal electrical activity. Okay, that is the reason why you need to create this multiple incisions or the scars. Okay, that will interrupt the abnormal electrical activity, and thereby your re-entry will be aborted, right? Re-entry will be aborted. Okay, and you see, even there can be biatrial maze lesions also, right? You can see that these red color lines, whatever you are observing within the atria, they are re-entry, macro re-entry. Now, these blue color lines, they are nothing but, that is, you are giving the incisions, multiple incisions in both the atrias. So you can see there is no macro re-entry further. You are having only blue lines, which is nothing but your incisions or scar formation, right? So these incisions, you know, they create a scar tissue, and this particular scar tissue will block the abnormal electrical impulses that causes atrial fibrillation, and that is what is called as the Cox-Maze procedure. And the other alternative therapy is the placement of the left atrial appendage device. Now, what are all these various left atrial appendage devices that are being available is, okay, so that includes, number one, the Watchman device. Okay, so this is actually the Amplazar device here. All right, okay, let me tell you the names of the devices. One is Watchman device, the other one is Amplazar cardiac device, and one more we have, that is Lariat device. These are the one which usually we follow, or Lariat plug or Lariat device. So what we do here, you can see that here. So within the left atrial appendage, because the left atrial appendage is the site where the thrombus formation occurs, right? You need to place a device, at this place. Once you place this particular device, you know the thrombus which is formed in this area will not enter into the left atrium. So this is about your Amp+R device, right? Similarly, you see here, this is the Watchman device. This is the Watchman device. So what these devices do? They seal off the left atrial appendage, and thereby it will prevent the clot from the LA appendage to enter into the left atrium. So this is about the how to prevent the cardioembolism or how to reduce the thromboembolism, right? And the next important thing is rhythm control in case of the chronic AF. So if you take this rhythm control, right, in the rhythm control we have two options. One is giving the antiarrhythmic drugs, and the other option is the catheter ablation. Now, whether to give antiarrhythmic drugs or whether to do the catheter ablation, that all depends mainly on the patient risks, depends upon the patient symptoms, right? So now if you take this antiarrhythmic drugs, which are all the antiarrhythmic drugs? So basically what is that you are doing in the rhythm control? That irregular rhythm, you are converting that into the sinus rhythm. So definitely when you convert the patient into sinus rhythm, the advantage is that the survival of the individual will be increased, because once you convert that into sinus rhythm, the cardiac output increases basically, right? And now if the individual is still in an irregular rhythm, that irregular rhythm, it is the marker of the disease activity, right? It is the marker of the disease activity, right? More irregular is your rhythm, more is the disease severity that you have to know. Okay, now the point is which particular group of patients they require the rhythm control, right? Let me tell you now. Number one, patients with symptomatic paroxysmal AF, okay, that is one set of patients. Second, patients with recurrent episodes of patients with recurrent episodes of symptomatic persistent AF, right? Recurrent episodes of symptomatic persistent AF, right? Third indication is AF with difficult rate control, right? AF with difficult rate control, okay? Convert them into sinus rhythm, right? Fourth is AF with decreased LV function. In these patients also, rhythm control is very important, right? So these are the group of individuals where you need to give the antiarrhythmic drugs or where you need to do the catheter ablation, right? Now, the patients who are having the heart failure, what is the preferred rhythm control strategy? In patients with heart failure, due to reduced ejection fraction, in these patients having AF, the preferred strategy for rhythm control is the catheter ablation, okay? Catheter ablation is more preferred than compared to that of the antiarrhythmic drugs, because the antiarrhythmic drugs themselves will cause this cardiotoxicity. That is the reason why in patients with heart failure with AF, catheter ablation is preferred for rhythm control rather than giving this antiarrhythmic drugs, okay? Now, let us try to take up the individual scope of the AF. Like, what are all the various forms of AF we have discussed? Like, we have discussed recurrent AF, we have discussed paroxysmal AF, we have discussed persistent AF, we have discussed permanent AF. So, in individual forms of AF, like how is the treatment strategy that you need to do? Let me discuss that. Now, if the individual is having first episode of persistent AF, then these patients, they require everything. What do you mean by the word everything? Right? They require rate control, they require rhythm control, right? And they require the anticoagulation also. Okay, they require anticoagulation also, right? That is in a patient with first episode of persistent AF. Now, you take the pharmacological therapy for maintaining the sinus rhythm. What are those antiarrhythmic drugs? See, basically the goal of the pharmacological therapy is to maintain the sinus rhythm, right? Or the goal is mainly to reduce the episodes of the atrial fibrillation. That is the goal of the pharmacological therapy, right? And this particular antiarrhythmic drugs, they are having their own risks, they are having their own side effects. That is the reason why you need to selectively consider the antiarrhythmic drug, right? Selectively consider the antiarrhythmic drug for converting the patient to sinus rhythm. Okay, right. Now, if you take one by one. So, okay, what is the role of these beta blockers and calcium channel blockers in the rhythm control? See, these beta blockers and calcium channel blockers, what they do? They reduce the heart rate, that is, they reduce the ventricular rate, and thereby they will improve the cardiac output and thereby improving the symptoms, right? Now, these particular patients who are taking beta blockers and calcium channel blockers, if you add antiarrhythmic drugs, these particular patients, they have a very good conversion of irregular rhythm to sinus rhythm. Okay, so that means what I mean to say is, along with antiarrhythmic drugs, you also need to continue the rate controlling drugs. That is what I mean to say. Okay, now if you take the antiarrhythmic drugs, we have class 1 antiarrhythmic drugs, which are sodium channel blockers. And what are these examples of sodium channel blockers which are your class 1? That includes flecainide, right? That is one. Number 2, propofenone. Number 3, disopyramide. So these are the class 1 antiarrhythmic drugs which are sodium channel blockers, and these are the group of drugs given in patients without structural heart disease. Okay, given in patients without structural heart disease. If the patient is having structural heart disease, we have the other alternative drugs, I'll tell you. But the limitation of these particular drugs is they are negatively inotropic. Right? They are having negative inotropicity. And the other thing is, these drugs itself, they are pro-arrhythmic. Right? These drugs itself, they are pro-arrhythmic. That is the reason why, because they are having anti-arrhythmic property, they are also having pro-arrhythmic property. That is the reason why they should be avoided in patients with coronary artery disease and in patients with the heart failure. That means what? You cannot give this in case of structural heart diseases. You cannot give these drugs in case of patients with heart failure and coronary artery disease having atrial fibrillation. Apart from this, whatever the risk factors or whatever the etiologies of atrial fibrillation is there, in that patients you can give this. Okay, right. Now, what are the group of drugs that you will be giving in patients with coronary artery disease or structural heart disease? In these patients, we give class 3 anti-arrhythmic drugs. Okay, and these include sotalol. This sotalol, it comes under both. It is also a beta blocker. It is also a potassium channel blocker, which is your class 3 anti-arrhythmic drug. So this class 3 agent, that includes sotalol, and the other drug is your dofetilide. Right? The other drug will be dofetilide. Okay, this can be administered comfortably in patients with coronary artery disease or the structural heart disease. But the only disadvantage is that these patients, like, there is almost 3% risk of the QT prolongation. And this QT prolongation will convert the patient to the development of torsades de pointes. So there is 3% risk of inducing the QT prolongation and torsades de pointes. That is what you need to take care. That means whenever you are given sotalol and dofetilide, you have to do continuous ECG monitoring. Particularly when you are giving this dofetilide, you have to do ECG monitoring. Okay, right? And sotalol it's fine, but dofetilide definitely, once it is being initiated, it has to be initiated only in the hospital setup. And you need to monitor the ECG, right? Now, the another antiarrhythmic drug is the dronedarone. Dronedarone, you cannot give that in patients with the heart failure. Okay, dronedarone, it increases mortality in patients with the congestive heart failure. And it is also not given in case of long-standing persistent AF. In paroxysmal AF, you can give the dronedarone, but not in case of long-standing persistent AF. Okay, right. Now, all these agents, whatever we have discussed, right, they have modest efficacy with paroxysmal AF. Okay, dronedarone you can give in paroxysmal AF, but not in case of long-standing persistent AF. And another antiarrhythmic drug is the amiodarone. So amiodarone is more effective, right? And it maintains the sinus rhythm in approximately 2/3 of patients in whom you are giving this amiodarone, right? And this amiodarone can be given comfortably, right? Can be given comfortably in patients with heart failure and as well as the coronary artery disease, right? But still, more than 40% of patients who are receiving amiodarone, they have amiodarone related toxicities, right? When the patient is taking amiodarone for a long term, you need to do careful monitoring of the toxicities of the amiodarone. Why? Because amiodarone, it can cause the liver and as well as the lung fibrosis. So you need to monitor the liver function test and as well as the lung. And not only that, this amiodarone is also associated with thyroid abnormality. It can cause either hypothyroidism or it can cause even hyperthyroidism. So long-term monitoring is definitely required. Okay, so that is about your rhythm control by antiarrhythmic drugs, right? Now, the other alternative method is the catheter and surgical ablation for maintaining the sinus rhythm. Okay, so if you do a successful catheter ablation, remember, successful catheter ablation will avoid the requirement of the antiarrhythmic drugs, and thereby you can prevent the drug toxicity, right? And you can prevent the daily usage of the drugs. Okay, but that effective catheter ablation completely depends upon the operator experience. Okay, right. Now, if you take the two combinations, if you do head-on trials, head-to-head trials, whether it is catheter ablation or whether it is antiarrhythmic drugs, remember, for patients with previously untreated but recurrent paroxysmal AF, okay, patient with recurrent paroxysmal AF, in these patients, remember, catheter ablation is more efficacious than compared to that of the antiarrhythmic drugs, right? Then, so in paroxysmal AF, what is the preferred treatment? Catheter ablation, right? Then you take in case of the persistent AF. See, long-term control of AF is more difficult to achieve in patients with persistent AF. Why? Because in persistent AF, there is extensive atrial abnormality. That means the arrhythmogenic focus, right? There is extensive atrial abnormality. Why? Because there is wide arrhythmogenic focus within the atria in case of persistent AF. Okay, and these patients with persistent AF, they are also associated with greater comorbidities, right? They are also associated with greater comorbidities in these patients. So that is the reason why achieving the rhythm control in case of persistent AF is not that easy, right? So what are all the options that we can do in these patients? Let me tell you. So one is the catheter ablation. Okay, so catheter ablation in case of these patients, it involves the percutaneous venous access. Typically, what is that percutaneous access that we take is, venous access we take the femoral vein access, right? And the other way by which you can approach the entire atria is by transatrial septal puncture. And the other approach of catheter ablation is the radio frequency ablation or the cryoablation. Okay, so these particular methodologies of the catheter ablation, they will detect and they will isolate the left atrial regions which are arrhythmogenic. And what are the very common left atrial regions which are arrhythmogenic? They are present around the pulmonary veins, right? The common arrhythmogenic focus, it is present within the pulmonary veins or around the pulmonary veins. Okay, now these particular catheter ablation, what it does is it will pick up what is that arrhythmogenic focus, and it abolishes the triggering activity. So these will abolish the triggering foci which are present within the pulmonary veins or around the pulmonary veins. Okay, now the only thing what is important here is, in case of persistent AF, because there is extensive atrial abnormality, by doing this you need to achieve, right, you need to achieve extensive area of ablation, right? You need to achieve the extensive area of ablation is very much required. Okay, right. So that is about your catheter ablation. Apart from catheter ablation, now you see here, so this is one image, right, which is showing you like where you are doing these red color dots, right? These are all the ablative focuses, these are the triggering focuses, and these are where all these being distributed. These are being distributed across the right atrium and as well as the left atrium. Okay, right. Now the other way by which you can do the treatment apart from the catheter ablation is, one is the laser beam radiation, right? These are, the alternative sources of energy. Apart from the electrical catheter ablation, the alternative energy sources is, what they do is, even they also ablate the triggered foci, that is arrhythmogenic foci. So what are those alternative energy sources? That includes, number one, laser beam radiation, right? Number two, external beam radiation. Number three, pulsed field electrocorporation, right, or electroporation. These are the alternative energy sources that will ablate the triggered foci. Okay, now the point is whether you require single ablation or whether you require multiple ablation. Now you take in patients with the paroxysmal AF, persistent AF, I have discussed now. What is that? They require extensive atrial ablation. Now you take in paroxysmal AF, is it single ablation required or multiple ablation required, right? And it all depends upon the comorbidities. So when you do a single ablation, right, when you do a single ablation, then the efficacy of the single ablation is almost 70% chances of reduction of AF in 1 year, right? And when you do multiple ablation, then more than 90% chances of reduction of AF will be there when you do multiple ablations. Okay, so that is about how many times ablation is required in case of paroxysmal AF. Now see, what is the very common area from where the foci is coming? That is from pulmonary veins. So there is one surgical procedure where we can do is pulmonary vein isolation procedure, right? Many patients, they become more responsive to antiarrhythmic drugs or become less symptomatic with reduced AF burden after this pulmonary vein isolation procedure. So you need to isolate the pulmonary vein, right? And you need to localize where is that arrhythmogenic focus, and this area has to be isolated, right? This area has to be isolated. Okay, by doing this pulmonary vein isolation procedure, the requirement of the repeat ablation, right, the requirement of repeat ablation is reduced. Okay, that is in case of the paroxysmal AF, right? Now you take patients with persistent AF or the long standing AF. See, patients with persistent AF or long standing AF, these patients, the ablation, it is less effective. I'll summarize everything. At the end, I'll summarize the entire rhythm control treatment. Okay, so the ablation, it is less effective in case of the persistent or the long standing AF. Okay, and why? Because they are having the extensive cardiac disease, they are having comorbidities are very high, and in these patients there is also evidence of left atrial enlargement. So that is the reason why the ablation is less effective in these patients, right? And if at all, if you are doing ablation, more extensive ablation is often required, right? Extensive ablation is often required. When you do extensive ablation, then you will be preventing that re-entry regions. Okay, you will be ablating that re-entry regions. Okay, right. Now selecting ablation targets outside the pulmonary vein. The point is, it is not only the pulmonary vein which is the focus for atrial fibrillation. There are certain areas outside the pulmonary vein also where you have that arrhythmogenic focus, right? What are those? You need to target that areas, right? That include, so how can you pick up that? See, non-pulmonary vein foci, how can you identify that? Non-pulmonary foci, they fire in response to supplementation of isoproterenol. In that way, you can identify that non-pulmonary vein foci, right? What are those? They include the areas of, right? They include the areas of the atrial fibrosis, right? And they include the areas of IVC and SVC entry into the right atria, right? So these are the non-pulmonary vein foci, right? Non-pulmonary vein foci. Now these particular areas, right, that is non-pulmonary vein foci, that is your areas of atrial fibrosis and regions with repetitive rotational or focal activation during AF. Remember, these patients, they require more than one ablative procedure, right? These patients, they require more than one ablative procedure to maintain the sinus rhythm, right? To maintain the sinus rhythm. Why they require more than one ablative procedure? Because of the lack of lesion durability. The ablation what you have done, that may revert back again into a triggered foci. So you need to do multiple ablations and more than one ablative procedure has to be done. Why? Because of lack of lesion durability, right? And because of complex atrial substrate. What is that complex atrial substrate? That is in the form of the atrial fibrosis. For this reason, you need to do multiple ablations and more than one ablative procedure is very much required. Okay. Now, so we have discussed like multiple methods of the rhythm control. Let me just summarize everything now. Paroxysmal AF, persistent AF, how is that you need to handle? So you just see this table. Okay, very, very important. Now suppose when the patient is having paroxysmal AF or persistent AF without major risk factors, persistent AF with major risk factors, paroxysmal or persistent with heart failure with reduced ejection fraction. These are the clinical scenarios. Now, in all of these, first and foremost, very important is ask the patient what he wants to get it done, whether antiarrhythmic drugs or whether it is the catheter ablation. So you need to give the option, medical or catheter ablation. You need to give the option to the patient. Then if it is paroxysmal AF, then catheter ablation, the class of recommendation is class 2A, right, for paroxysmal AF. Preferable is the antiarrhythmic drugs. Okay. Now, you take paroxysmal AF without major risk factors for AF recurrence. In them, the catheter ablation is class 2B recommendation, right? The preferable is the antiarrhythmic drugs. Only when the antiarrhythmic drugs fail, in them you need to perform the catheter ablation. Okay, right. Now you take the third scenario, persistent AF with major risk factors for AF recurrence. In these patients, let me tell you, catheter ablation will be class 1 recommendation, right? That is persistent AF with major risk factors of AF recurrence. The catheter ablation is class 1 recommendation, no doubt in that, right? If catheter ablation procedures are not available, then you can give antiarrhythmic drugs. If antiarrhythmic drugs are failing, then you need to refer the patient to a center where catheter ablation is there. That is for persistent AF with major risk factors of AF recurrence. And paroxysmal or persistent, whatever it is, but there is heart failure with reduced ejection fraction. In these patients also, catheter ablation, it is the class 1 recommendation. If option is not there, then give antiarrhythmic drugs. If the antiarrhythmic drugs are failing, then you refer the patient for catheter ablation. So this is about like what to start with. Is it antiarrhythmic drugs or is it like catheter ablation? So if you see the complications of the catheter ablation, so the complications, if you see the percentage wise, right, catheter ablation has almost 2 to 7% risk of the major procedure related complications. And what are those? Number 1, stroke. Okay, this particular stroke, it is seen in almost 0.5 to 1% of individuals. Then this catheter ablation, occasionally or accidentally, it can cause the puncture of the pericardium, wherein the patient can develop cardiac tamponade, or like if the patient has the puncture of the endocardium myocardium, then there can be development of cardiac tamponade in almost 1% of individuals. Then the another important procedure related complication is the phrenic nerve paralysis, right? And the third important complication is the bleeding at the femoral vein site. Okay, that is where you have punctured, there can be bleeding from the femoral axis site. Okay, and there can be also the fluid overload, right? There can be also fluid overload with heart failure. So these are the complications of the catheter ablation, right? Now, another thing is you are also doing the catheter ablation at the level of the pulmonary vein itself. Now, what is the complication of catheter ablation at the level of the pulmonary vein? At the level of pulmonary vein, it can cause the pulmonary vein stenosis. Okay, and this pulmonary vein stenosis, this can happen within weeks to months after the procedure, right? It can happen within weeks to months after the procedure. Now, how will you diagnose, right? How will you diagnose this pulmonary vein stenosis, right? Once there is pulmonary vein fibrosis, what will happen? The blood from the pulmonary veins will not be able to enter into your left atrium. So pulmonary venous pressure increases, pulmonary capillary wedge pressure increases, and thereby these patients, they develop dyspnea, right? Or these patients, they develop hemoptysis. Okay, so dyspnea or hemoptysis, these are the features of the pulmonary vein stenosis. The another complication that is anticipated is the atrioesophageal fistula. Now if you take this esophagus, it is very close by, or it abuts the posterior wall of the left atrium, right? It abuts the posterior wall of the left atrium. Okay, so when this esophagus, when it is abutting the posterior wall of the left atrium, now when you are doing this catheter ablation of the left atrium, occasionally, right, the chances of development of the atrioesophageal fistula is less than 0.1%. So occasionally you may create an injury to the left atrium and then causing the ulcer into the esophagus. Okay, the ulcer in the esophagus and as well as the puncture within the posterior wall of the left atrium, that will create a connection, and that particular connection is called as the atrioesophageal fistula, right? And the chances of development of that is less than 1%. Okay, and remember, what are the complications associated with the development of this atrioesophageal fistula? That is, these patients, they present as endocarditis, because the foreign material from the esophagus will be entering into the left atrium, and that can predispose to the endocarditis. And even these patients, they also develop stroke, because the foreign material from the esophagus will be entering into your left atrium, which will enter into the systemic circulation. Like if it enters into your cerebral circulation, the patient will develop stroke. Okay, and this particular esophageal ulcers causing fistula, that can happen 10 days to 3 weeks after the procedure. That is the reason why early diagnosis of this atrioesophageal fistula is very, very important, right? And if there is delay in the diagnosis, there can be a likely death of the individual. Okay, right. Now, how will you diagnose this atrioesophageal fistula? That is by doing a chest CT scan. So, how you have to do this particular chest CT is, this chest CT, it should be done along with water soluble or IV contrast you have to give. So once you give the contrast, it will be entering into your right sided circulation, and then from there it enters into the left side circulation, where you can visualize that with the help of the CT. Okay, right. So it is diagnosed by the chest CT. Now always remember, very, very important, if you are suspecting this atrioesophageal fistula, endoscopy should be avoided, right? Endoscopy should be avoided in patients with suspected fistula, because when you do endoscopy, there is risk of air or esophageal fluid embolism. So this particular embolism from the esophagus, it can enter into the left atria, which can enter into the systemic circulation. So that is the reason why, in order to prevent the air or esophageal fluid embolism into the left atria, the endoscopy should be avoided. Then how do you treat these patients? So you need to do a definitive repair. Surgical treatment is required. So emergency, right? Emergency surgery is definitely required in these patients. Okay, right. So that is about the complication with the catheter ablation, that is atrioesophageal fistula, right? And the next thing is the surgical ablation of the AF. Okay, now how is that you should be doing this surgical ablation? Surgical ablation is what you need to do: thoracotomy and then ablation of the atrial fibrillation. Okay, so surgical ablation most frequently it should be performed along with the other cardiac disorder, right? If you are doing any cardiac valve surgery, parallelly you do the surgical ablation, or if you are doing CABG, parallelly you do the surgical ablation. Okay, but very less commonly the right? Very less commonly, we do it as the standard alone procedure. Surgical ablation is what? Like thoracotomy, doing thoracotomy and then doing the ablation. That is called surgical ablation. Okay. Then we have what is called the hybrid procedure. What is this hybrid procedure? Hybrid procedure is the one which is very much useful in patients with persistent atrial fibrillation. So in hybrid procedure, here you will do a combination. That is, you will do surgical ablation. Along with that, you will also do the catheter ablation. Right? Along with that, you will also do catheter ablation. This is what is called as the hybrid procedure. Right? And that is mainly indicated in patients with the persistent AF. Okay? Right? Definitely, the hybrid procedure, if you take, if you compare with catheter ablation, definitely the hybrid procedure will have more efficacy than compared to doing only catheter ablation. Okay, right? And next is, how will you manage? Right? Okay, one second. In case of this hybrid procedure, what is that you are doing about the surgical procedure? Surgical procedure that you need to do is, you need to do surgical removal of the left atrial appendage. Right? That will reduce the risk of stroke, and at the same time you need to do the surgical ablation as well. And the catheter ablation, what does it include? The catheter ablation, that is this SA nodal ablation. But when you are doing this SA nodal ablation, there is risk of requirement of the pacemaker. So you need to balance the thing and then you need to do this procedure. Okay, that is what is your hybrid procedure. So definitely when you do this hybrid procedure, usually we avoid it because there is higher morbidity with this hybrid procedure, mainly that surgical ablation. Okay, right? So now the last important thing is the risk factors for and lifestyle impact on the atrial fibrillation. There is a very strong evidence that AF is associated with obesity, right? Very strong association of hypertension with atrial fibrillation. Very strong association of sleep apnea with atrial fibrillation. Very strong association of alcohol use with atrial fibrillation. Okay, so that is the reason why you need to do aggressive treatment of these particular risk factors. When you do aggressive treatment of these risk factors, that will reduce the episodes of AF in some patients. Okay, that is the reason why the risk factors have to be treated appropriately, right? And what about the exercise? The amount of exercise appears to have complex relationship with risk of AF development. Like if you take exercise, right? If you take exercise in males, okay, in males, it is a U-shaped curve exists. Now, what do you mean by this word, the U-shaped curve? AF risk, it is very high in patients who are having sedentary lifestyle. Okay, in males, AF risk is high in patients with sedentary lifestyle, and the AF risk is also high who participates in extensive athletic activity. Okay, so AF risk is also high in extensive athletic activity, right? Whereas in the same males, when they does moderate exercise, then the AF risk is less, right? Then there is lower risk of the AF in case of the moderate risk patients. That is in case of males, that is a U-shaped curve. Whereas you take in females it is the linear relationships, right? It is a linear relationship that will exist between the exercise and as well as the AF risk. What is that linear risk? That is AF decreasing continuously with increasing exercise, right? AF decreasing with risk of AF decreasing continuously with increasing exercise activity. So U-shaped curve in males, linear curve in linear relation in females. Okay, and the other risk factors are the intake of caffeine. See, caffeine, what has been thought was caffeine intake is often invoked as a risk of the AF development, or caffeine, it has been found to be a trigger for the AF episode. But this caffeine intake in a large cohort studies, right, when the large cohort studies were done, what has been demonstrated was a contrast has been demonstrated. What is that contrast which is being demonstrated? What was the thought process? Caffeine intake is associated with triggering of AF, but the large cohort studies have demonstrated that there is modest decrease in the AF on intake of caffeine. Okay, and another important risk factor is the psychological stress, right? Psychological stress, even this also is associated with increased risk of the atrial fibrillation. And one more important risk factor is the genetic predisposition. Okay, so in the genetic predisposition of AF, what has been found is the first degree relatives, right? The first degree relatives with AF, remember, they are having increased risk of AF, right? First degree relatives of AF, they are having increased risk of AF. This is called as the familial form of AF, right? This is called as the familial form of AF. Okay, so this is about the treatment of atrial fibrillation. So at the end, what you need to know, the treatment in case of AF, it requires the integrated approach. What is that integrated approach? Risk factor control, rate control, rhythm control, and stroke prevention. Everything is required in case of the treatment with the atrial fibrillation. So this is what we have discussed in this particular session, right? What are the main goals of the treatment? Is it like cardioversion or anticoagulation first? How will you achieve acute and chronic rate control, and what is the advantage of it? Stroke prevention, what is that you will be doing to prevent the stroke? How will you achieve the rhythm control? Catheter and surgical ablation, which is being preferred? What is the hybrid procedure? And what are the risk factors? And how will you control them? So this is what is about the treatment of atrial fibrillation. Thank you very much.